Now they dark desire, poop and peeing like when you can't stop. Things you don't hear at the coffee shop.
All right, I guess we should embark. So we had talked about sort of establishing a foundation a little bit, just kind of talking generally in order to establish things for future talks that might be more in depth. So, so I think that sounds like a great way to begin. I'll learn some things that I don't know about you too, and we've talked a lot, but there are some things that I want to know still. So
cool.
I think the best way to begin is to hear from you about how you started doing what you do and what drew you to your work, and particularly what you're specializing in.
I certainly never envisioned my career looking like this when I came out of PT school, but I just started out as a regular orthopedic physical therapist, and I loved the biomechanical functionality of the body, how the joints and muscles work together to move things, and how it's like sequencing or domino effect, how one thing causes dysfunction in another area. Then I honed in on the pelvis. I loved the pelvic alignment. I loved working with postpartum women off the bat. And I had a colleague of mine say, you know, if you're going to really know the pelvis, how do you not get to the inside muscles and understand the inside muscles and how those work? And so I started off on the endeavor of learning more about the inside workings of the pelvic system, the bladder, bowel, the whole abdominal wall, and the internal contents. It led to just this steamroll effect and this curiosity within me. Of course, being a woman, having had 2 children, these aren't things that you learn in PT school. It's a complete specialty. And there's different staging of the courses you have to go through. So once I started embarking on level 1 training, it was like the questions started filling my mind and I wanted answers. And so it's been 15, 16 years of just focusing pelvic and growing my knowledge in the pelvic area. I also just love hearing stories from women, and these stories are all unique and all very special and different. But we can't discount the different systems of the body and how they all influence the reflexes within, the things that we take for granted that are just working in our bodies every day. We never have to think of them until they start affecting our lives, really.
Yeah, that's really ambitious of you, it seems like to me, because it strikes me that you were in a profession that is the knee, it has the bone and a tendon, it's the muscle, not to discount that, but this is just a unique part of the body that, like you say, you can go further and further. The uniqueness of people's bodies and experiences with all of those organs and everything must just be endless, and it is very different,
very intricate.
So that's amazing that you went down that road and figured, well, I want to discover more about what has got to be, I'm sure we're biased, but it's got to be the most complicated part of the human, is it not? I mean,
isn't it? I mean, just even emotional control, like thinking about having butterflies or being excited. We feel that in our gut.
Yeah.
We have this like emotional hub within the system, and it affects digestion. It affects the way that our bladder functions and how we control pain.
Yeah.
All this like auto regulation, it happens from the center of the reflexes and the nervous system.
Yeah.
So even just placing hands on somebody who has had trauma or have had circumstances in their lives, they may not even think of it as trauma, but circumstances that shape our ability to feel. When you place hands on somebody and they feel kind of this trust, it allows their body to respond. So I like to say, like, I'm not fixing anybody. I'm leading somebody's body to figure out what to do and how to do that. I'm facilitating the healing process maybe, but I'm certainly not healing someone's body or fixing them or changing their alignment. I'm allowing their bodies to fall into these new patterns. It's really rewarding, very rewarding.
Yeah, you're sort of meeting people where they are, I suppose. We can go into a lot of that in terms of the landscape that you're entering, but it's maybe just what is the pelvis? I mean, what is the area that you're focused on, and where does it stop and start? It doesn't, obviously, is kind of what you're saying. Everything's connected. But what is it that you're kind of dealing with?
Well, I'll start where people don't want to start, is to think about the internal stuff. And that can be alarming when they're starting or thinking about going to pelvic physical therapy. It's like, oh, I don't know, that's going to be uncomfortable, or I don't know what that's going to be like. Let me start with.
It's funny. We don't see this part of our body like you would other parts that you're looking at arms and knees and shoulders. I mean, this could be me, but I feel like people are just very unfamiliar, even in this day and age, with what's going on down there, because you can't see.
That's right. You can't see. And like, you don't know. You feel the pain, or you feel the urgency, or you feel the constipation, you feel the symptoms, but you don't know. And that's one of the things I tell people when we enter into an exam, is I explain the exam, what it will look like, where you're laying down. There's 3 kind of layers of depth that I'm working toward when I'm doing an internal assessment. And the first layer is right there at the vaginal opening. It's right there at the vulva. So I don't even have to go internal in order to get a lot of information that's helpful. And then after, it takes 5-10 minutes to really do an assessment. But then it's interesting, because then once we dive in and we start doing the assessment and we're finding things to work on right then and there, I'm working on them right then and there. And people can feel the pretty immediate changes sometimes. Certain areas, for instance, bladder urgency. You can kind of palpate around that urethral area in the front muscles, if you will, of the pelvic floor. And I'll touch those areas and say, does this make you feel like you have to pee? And they're like, it does. But I just went. Like, I know I don't have to go. And then I can do a release technique and say, does that feel better now? And is that what your urgency felt like before? And we can get really good results. They get off the table and almost immediately feel better. So 3 layers. The farthest in we're going is about the length of a finger, gloved hands, lubrication. But it's checking for 3 main points. One is pain. One is how the muscles are functioning, whether they're strong, whether they're weak, or whether they are confused, I guess. Like, we call it motor control, having impaired motor control, not knowing how to fire the muscles the right way, holding the breath, things like that. And then other symptoms that might arise during the exam. So whether it's urgency or sensation, burning, sandpaper, things like that. We're kind of looking at tissue health, which goes along with a lot of hormone issues, skin integrity, things like that. So what we're looking at in pelvic therapy is really the whole body. You said it. I mean, somebody that has an ankle sprain, a history of an ankle sprain, it created instability in their ankle. How does that translate up the chain, up the leg? And how does their hip respond? Does their hip overfire now because their ankle is weak? And now they have pelvic floor tension on one side of their body. And that creates the acuity of the pelvic bones going into a bit of a rotation. So, we've all heard of muscle memory, and how muscle memory creates motor patterns. We all posture a certain way. We hold ourselves a certain way, and that creates imbalances within the body. How does that affect inside? How does that affect those deep core muscles? So it's really anything from the throat down through the hips, sciatica. But I'm very curious when I find certain findings to look outside of just the pelvic area and into the rest of the body, and asking a lot about history and
So you're seeing a spectrum of people probably that are come to have a problem later, like you see this something has kind of built and eventually created a problem. Other people like me, I guess, who came to you because of radiation or some sort of trauma or injury, I guess, that could occur, right? So it would be something really acute. Is that generally what you're seeing? People are coming in with just, I've discovered a problem.
I discovered a problem, or even I've always had a problem and didn't realize that there was help for it. I mean, I see people with constipation issues. I've struggled with my bowel system my entire life, they'll say. And I've tried all these things and all these over-the-counters and prescription meds. And so the chronicity of a lot of these issues, women, I think, live with these symptoms because they're almost normalized in the population. It's so common. And there are some very easy treatments. I can get people better sometimes in just a few visits, just so there's some training.
Incredible. What now? You said chronicity. What does that mean?
Like just long-term symptoms. I've
I
had it
see.
my whole life, or I've had it so
The
long.
chronicness of, okay.
But
Mhm.
how does that rewire your brain when you struggle with something like that for so long? Now you're developing fear, aversion. You stay away from those activities,
Yeah.
even taking constipation as an example. If somebody has struggle having a bowel movement and then they feel the urge to have a bowel movement, what's the first thing they think of? Oh no. And
Yep.
then how does that wiring in the brain create fear, create tension, and now it makes it even harder to poop? And then they're like, yup, there's the problem, just as I suspected.
Yep. Yep.
So
So when you're training, you can train people to control that. It's a muscle thing. It's clearly a brain thing. We were talking before about the hand is on the doorknob, and when you've got to go and sometimes
yeah,
you might lose it at that point when you wouldn't have minutes before without that door being there. So that is, I think
yes,
that
great
is almost
example.
magic to
Yep.
me that your brain can do.
And how
in
it
in
can
a bad way.
start.
Certainly it can do it in a
Yeah.
good way. Yeah.
And how it can begin with, geez, every time I get to the door, I have to pee. And then you drive into the driveway and it starts happening. You're like, yep. And then it starts turning into leaking. So it kind of has this progressive nature. And part of that is because we're kind of giving into the problem and not doing anything to fix it when you start noticing the issues.
Yeah.
And there's some very simple reflexive exercises you can do to turn off a bladder urge when the urge presents.
Life changing to people. So many enormous population of people, probably mostly older, that are
Yeah.
experiencing this and could be helped. It's
And we all know the lifespan of a woman and all the body changes that we go through. And it is a very natural process. However, there's a lot of imbalances that are happening. I think, especially environmental, as we are going through decades and decades, we're having more common issues. And really, it starts with just education of what the reflexive system, how it operates,
yeah,
and then matching some of your behaviors to what that should look like.
yeah,
We steer away from the things we should be drinking because other things taste so good. And over time, that can cause some problems. So it can be as simple
yeah.
as changing your lifestyle habits.
Yeah, that happens to me all the time. Some sort of
Mm.
physical thing will be happening to me, and I'll be like, well, it's a mystery. I guess I'm dying or whatever. And then somehow it clicks or never clicks that you've been drinking energy drinks for 4 days because you had a long day, and it's just like,
Absolutely.
yeah,
You go on vacation and
yeah,
bottoms up. Yeah, and you get off vacation and kind of like, wow, I got to do like a cleansing. I'm going to stick to water for a few days
yeah, yeah.
just to kind of reset the balance.
Yeah, I wish our brains were a little smarter to be able to ping us when
Yeah,
we have to dig it.
they're very attracted to the senses. It's things that taste good and feel good. And
Yeah, what
yeah,
animal we are. Okay.
yeah.
Yeah. So to that, I also wanted to, you're sort of mentioning how you're seeing people where you're meeting them. We've talked about this. This is such an interesting subject to me, but where in the pipeline do you come in usually? How are people
Mm.
finding you, and how do you enter their lives?
Great question. Usually word of mouth is the biggest one. And I have a lot of sweet success stories. And when somebody is discharging from my services, I'm like, share this with your women friends and your sisters and aunts and just people you care about, because there is so much help out there for these problems that everyone just thinks is normal and keeps living with. And we
Mhm.
laugh about it. We just get
Mhm.
together with our friends and we talk about wearing our laughing pads, and there's treatment. So word of mouth is really the biggest. And when do I enter in? Usually too late.
Sure.
If a
Yeah.
symptom has started within a month or two and you can get in and start learning how to curb and not allow these things to steamroll, the earlier the better. So I really say don't delay, and don't delay because just one visit, I spend an hour with my clients, and you don't have to walk through a clinic and wave to your friends and your neighbors and your coworkers. Like, it's a nice private setting. We have a very kind of safe space here where stories can be shared, tears can be shed.
Yeah.
But
Very
give me
important.
1 hour, give me 1 hour. And by the end,
Yeah.
I'll have heard your story. understood and we've done an assessment to figure out what the driving kind of driver is for the symptom. And I can already steer you on your way to what to do at home to begin the healing process, whatever that was going to look like, because it's such a
Right.
wide variety. But
Are,
this setting
yeah.
of, I'm sorry.
Well, yeah, no, go ahead. It is interesting because I was familiar with going past people doing their little squats and knees and stuff, and then you're experiencing this range of emotions and this intimate thing, and you're in a weird position, and it can be nice to know that you could go to a private spot that's welcoming and there's somebody there to talk to. That's
right. Exactly.
Focused on a particular area and problem.
Yeah. And it's very, very private matter, and stories sometimes start and then they really open up by the end. So if you're watching this and considering coming into pelvic, you don't have to come in and bear all. Just come in and be you and just share what you feel comfortable sharing. And we kind of peel away. We peel away at that, the layers.
So are you feeling like physicians are mentioning this to their patients when this comes up? I mean, we've talked about, I've experienced real need for this that I was not aware of. And even in my situation, having anal cancer, that I was not directed to you immediately. And I found that to be a real void in the system here. So I'm wondering, are you finding that people are referring and mentioning it when they're in a medical situation? I mean, your first stop is your primary.
Yeah.
And I assume for things like that, unless you're involved in treatment or something.
I think it all goes to education on the provider themselves. Yes, absolutely. We're getting direct referrals from physicians. Absolutely. We're getting great primary care physicians that know the right questions to ask and send the referral to pelvic rehab first as a low-hanging fruit kind of and I know how to identify if this is beyond my scope of practice. I'm referring back over to the primary to go to urology, and I've done that quite a bit, whether it's a driver from the spine and I think that they need to see a spine specialist or a urologist, or God forbid an oncologist, or going through some testing. I refer back to the primary care to help navigate that. But definitely it is growing within the medical profession that pelvic physical therapy is known more about and is being utilized. It's also growing because clients themselves, us as women, are getting more educated because of resources on the internet. And there's so much you can learn via watching videos. And by all means, I encourage that. But if it's not working for you, that's when I would recommend coming in for evaluation. But word of mouth, doctor referral, it's growing, and I'd like to see it growing even more before women are even considering having children, have an examination. And the other good thing about it is, if you're seeing, like myself, prior to having a child, what an amazing baseline understanding of how your body is functioning at this stage, and then the next stage during pregnancy, and then the next stage post. And even through cancer, you're approaching menopause age. It might be good to have a physical therapy eval, get established. It's almost like having this, you're going to be facing menopause. And then after some changes happen for cancer diagnosis and starting the treatment process, get into pelvic rehab as soon as you can, prior to having chemotherapy, prior to having radiation, so you can kind of establish these baseline and to learn what it is you might be able to expect as you're going through these treatments.
Yeah, I assume you do too. Just it needs to be mentioned a lot more and sooner. And
that's why we're here.
And and have you be on a team of people if they're
absolutely
assembled, and not have that be an afterthought. For sure, it's just so important. And there's a lot to talk about there. I know there's lots of things that need to be cured and problems that need to be solved. Those are all important, but
right.
But the things that you're focused on are so important too.
I think what you're referring to is just quality of life. I mean, oncologists are there to save your life, and they do an amazing job. Here we are today.
Yeah.
But then what does that quality of life look like for the individual
Yeah.
after going through treatment? And
Yeah.
oncologists don't have time. They often, with radiation treatment, pelvic radiation, they'll just hand the client this like hard white plastic dilator and say, use this, your vagina is going to tighten up, and they don't have time. Or maybe sometimes the knowledge on what that dilator program would look like. And a dilator program looks very different for each person. So it's important to have somebody that can follow you through that rehabilitation process and give you the right tools or resources to the right tools that are much more comfortable and don't provoke fear. And I think also reframing the rehabilitation in a way that's like, let's get your life back. Let's get your dignity as a human back, that you don't have fecal incontinence, pain with having bowel movements, intercourse even. Let's look at these tissues as a system and let's start treating them with gentle compassion. I mean, it's not just let's get in there and stretch the tissues. It's not very compassionate. But let's treat your tissue as if it's been damaged and it needs some healing.
Yeah.
And it's a very slow and guided process. And
it's part of the body. We can talk about this at another time, but that is supposed to provide pleasure. And I think that's very difficult for doctors to talk about.
Yes,
On the way.
asking the right questions. It's so hard to know what to ask because everybody is in different places, even with intercourse and with sex and intimacy. And we all have different stories and backgrounds on beliefs, and those all come into play.
Yeah. And maybe that is why it's difficult to talk. Doctors have a job and don't know how to probably approach people and don't want to do the wrong thing, but an immediate referral to someone like you I would think would solve the problem. Yeah.
Yeah, or they ask the questions and the answers they get, they're like, what do I do with this information? Refer it on to pelvic PT. That's what we do. And we get a nice chunk of time. We have time with people to have these conversations and dig in more. So having time really helps to unwind the nervous system.
Yeah. So much to talk about and discover, so many different aspects. I love it so much. I know that we're going to have to move through. Yeah. So do you want to end with some quick fire, just interesting factor?
Let's do it. Let's do it. Yeah.
Okay. All right. Factor fiction. Everybody should be doing Kegels.
Okay. Complex answer for factor fiction. I'm going to say fact with a quirk to it. So it's like riding a bike, right? You learn how to ride a bike, you never forget how to ride a bike. But things change in your body. Maybe you have knee pain or a hip replacement or something that throws you off that you're like, I can't ride a bike anymore. And that's kind of my analogy with doing Kegels. Like, some people never even think about it, but it's such a reflexive muscle that you don't have to think about it. That's the beauty of the Kegel, is it contracts when we cough and when we sneeze and when we pick up heavy things. Like, it has this functionality that we never have to think about. So I suggest to do Kegels to see if you can do Kegels. But some women will sit there and they'll just be able to squeeze and let go, squeeze and let go, squeeze and let go, or squeeze and hold and don't let go, and squeeze and hold and then release. And some people can do a nice job breathing in and exhaling and squeezing on the exhale. And if all of those things are easy to do, then you're riding your bicycle just fine. So that would be the people that I would say.
Sure.
Yeah, like, you can do it. Great, good job. You don't need to like sit there and do it per se. But if you're having dysfunction, if you're having problems, it may not be that you need to do Kegels. It may be that you've done too many Kegels. So, I mean, there's so much variability in that.
Yeah, but Kegel hour.
Yeah, you don't need to do a Kegel hour. Goodness gracious, no.
You and I need to do a Kegel.
Yeah. Oh, we need to do a whole hour talking about Kegels. Yes.
Or we can just do Kegels for an hour.
Or no, I don't think we should do that.
Okay.
That's funny.
Do men? I mean, I know men have a pelvic floor. I mean, do they do Kegels, or is that anything that comes into their lives? I don't know.
I think the difference.
Give them a platform. God,
and that's a whole nother hour. No, but I think the difference is the length of the urethra. And they have an extra valve that kind of helps to hold the urine in. Okay. So as far as doing your Kegels for men, really, I think what comes with aging or cancer changes or having had surgeries relating to the prostate, things like that, that can cause dysfunction. But yeah, they have Kegel muscles and they can do Kegels as well. But you have to remember every time we're loading our body, our core stabilizers kick in. So when we squat, our Kegel should be activating
Yeah.
reflexively. So
Yeah.
even just exercise, even you're kind of like, I don't know about Kegels, I can't feel what's happening. Walk, squat,
Yeah.
exercise. It's a
Yeah.
great
Focus
place to
on your
start
core. Yeah.
because those deep hip rotators are very intricately connected within the pelvic floor. And so you're exercising those muscles. It's just that you may not have that brain Kegel connection going. So,
Yeah.
but yes, men can. And it's kind of the same answer. If you
Yeah.
do too many, it can cause tension and it can cause other issues within the body. So it's about balance.
Yeah. Yeah.
Yeah.
That's right. Yeah. We don't want to become a tick or something.
Right.
Yeah.
I do
And
them
I
when
do
I'm
have
washing my
really
hands. I'm doing them when I'm driving. I'm doing them when
Yeah.
we don't want to be doing that.
I
That
know
can
I'm
create
one
more
of the people
problems.
that can get really ticky, and that could, yeah, that could be.
Oh, the other pet peeve, can I jump in? This just
Yeah.
led me to another pet peeve. Doctors and sometimes health professionals will ask you, can you stop your stream of urine?
Yeah.
Right, while you're peeing, because that's a
Yeah.
Kegel. And then when you say no, I can't, or yes, I can, it leads the person to believe that they should be doing that.
Oh.
And really, the answer is you shouldn't be doing a Kegel when you're urinating. So if you're somebody who has been asked that question and you're led to believe that doing Kegels when you pee is a good time, it's actually not a good time because it's rewiring what should be happening, right? Reflexively.
Really? I see. Uh-huh. Yeah, it does
Yeah.
seem like a good time because it's almost like you've got a barbell or you've got a
Yeah.
stream you can work, and that would seem, but no,
We
it's
should be
never,
relaxing at
yeah,
that time and
yes.
allowing our bladder to contract and our floor relaxing, and then out comes the urine. As soon as we close that off, we're disrupting the reflexive workings between the bladder and the
Yeah.
pelvic floor
Uh,
and
that,
actually interfering with that.
yeah, more stuff to talk about because
I know.
you and I've talked about that. It did occur to me that you how do you go? You have,
Yeah.
how do you sit and relax and breathe? And
I have a whole
I
thing on toilet
yeah,
training, how to sit,
yes,
what to do on the toilet. Again, we
yeah,
never have to think about it until there's dysfunction.
yeah. Even just how you're sitting could help a small problem or a large problem with
Very
how they're
quickly.
going. It's
Some
crazy.
of the habits that people have, and you just educate them in the first visit. I've had people not come back after that because they fixed the problem.
And you're like, oh, this is it. Yep, this is the
Yeah.
thing.
If
Okay.
it's a peeing issue, their stream is not coming out fast enough, taking forever. It's stop and go, or you have that post void dribble on the toilet seat, or you leave the toilet and have to come back. There's a handout that I provide. It's like, this is how to pee the right way.
Yeah, yeah,
And they can just fix it, right? Just like that.
yeah. I think that's great. I love the
Yeah.
spectrum of like, I'm going to talk to you for an hour, talk about a lot of things in your past, or I'm going to give you a pamphlet and that could help you. Like there's just, it's just a
Yes.
spectrum of ways to be helped here. Okay. So sex is painful for women after, well, I'll say after 50.
Yeah.
It's just painful.
Well, I recently read a study that said, what's that?
Fact or fiction?
Fact or fiction? Okay.
This is fact or fiction. Yes.
So I read a study recently that showed that the mean or the average sexual health peak for women, you'd never believe, it's age 52. And that is actually coinciding with menopause. So
Yeah.
figure that out,
Okay.
right? But I think,
Yes.
so sex does not have to be painful, period, at any age. I see women who are newly active and are told it's going to hurt the first time. And they're like gritting their teeth and crying, it hurts so bad. That's not normal. That's beyond normal. And then we have tissue changes postmenopausally that can cause. So we have to search for the driving cause for why there's pain. And there are a number of drivers. And so, no, sex does not have to be painful.
No.
Sex needs to be pleasurable. We're not going to want to engage in the activity if it doesn't feel good and bring a benefit to the relational couple.
Yeah.
It's all about pleasure.
Perfect. Do you have one that's in your mind, that a fact or fiction that you would like to just skywrite for people that have a misunderstanding of something that you
Yeah, so fact or fiction on the spot here.
Oh, well,
I want to say something about like when I have to poop, I should go poop. Fact or fiction?
oh, good one. Fact or fiction? Okay, let me see. I would say certainly yes, that's fact.
I mean, common sense is telling you it's fact, and reflexively, it's telling you it's fact as well. Your body is telling you to go, and you should go. How is your body telling you should go? Where do you feel the urge to have a bowel movement? And like, for instance, is
Yeah,
it
now I'm thinking about it more, and
like
you and I have been through stuff together. No,
when you feel like you have to go, there is
yeah,
a time where you
you
shouldn't
hang
go.
out for 5 minutes.
You should hang out for a little bit.
Yeah.
Let it marinate.
Yeah.
Drop down until you get what I call the knock at the door, which is like the anal sphincter message. Like
Yes.
if you just feel pressure or fullness, you're not quite there yet. And so analyzing your urge is
Oh, I
another big
love
thing
that.
that we work. It's a sensory piece. And so reflexively, when you feel the knock at the door, your reflexes have kicked in, your peristalsis is helping you out. And people will say, when you go sit down on the toilet at this point, I feel like I can just breathe and then my body just kind of, I don't have to work so hard. But if
Yeah.
you're forcing and rocking or holding your breath and bearing down, those are common strategies people try to do. And maybe it's a sensory problem. Maybe it wasn't that you waited to the point that it progressed to a knock at the door, or maybe you have pelvic organ prolapse. Oh my gosh, a whole nother hour where it's changed your ability to feel that sensation because there's a prolapse
Yeah.
interfering with that.
Yet another hour might be. Does this intersect with IBS and, people
Absolutely.
going a little too much? And
Yeah.
could you, help with that?
I have a whole soapbox on IBS. So many people come in and say, I have IBS and I learned how to live with it. But
Yeah.
IBS is really, it's a lot of rewiring from the mind-body connection.
Mhm.
And
Complicated because that they do
yes,
say,
complex.
well, there's something in your head, and that of course sends off trigger of, oh, it's just in my head. But that's not. It's complicated. It's in your head in a sense that it's related to your head. But
And once we get through the education about what that means, it's like it's not in your head, it's all in your head. It's not that you're making it up, or it's legitimately reflexive happenings.
yeah,
And there's IBS constipation, and there's IBS diarrhea, and there's an IBS mixed. And so
yeah,
really diving into nutrition, fluid intake, irritants, and then the stress management, sleep patterns. Like there's so much to helping to manage your IBS. I don't say fix it because we don't fix it. You manage it, you live with it,
yeah.
and you
But
manage it.
thinking about going, I feel like you have to go a lot, and you do, like you were saying before, you're training a whole other way of going, which is not helpful to go.
Correct.
Yeah,
That's
so
right.
That thing you were talking about, the waiting may enter into that part. Yeah.
Yeah. And it's getting into just satisfaction. How satisfied are you with your ability to poop? How much is it ruling your life? And if the answer is like, I don't even think about poop, I feel like I have to, you're normal. It's fine. Everything's great. But if there's any like fears,
I feel like we should do man on the street with that. How satisfied are you with your ability to poop? Let's see what we get.
Sign me up. That would be so fun.
So fun.
I tell you, if I could share, I'm not going to, but if I could share, I've heard there's not anything I have not heard in this treatment space.
Yeah.
Once in a while now, I get taken aback with something new. And sometimes we laugh a lot. Like it's really nice to be able to break some of that fear and tension with laughter. So
can details of these people be changed and we could hear more about that? I'm sure it'd make us all feel better if we heard some of the craziest things.
Some of the craziest things, we'll save that for the next one.
At some point in the future, do you think you could share, change the immediate details? Or
well, I have so many floating through my head. I'm like, it's like sorting the raindrops.
Right, we will do that. We'll have to do that.
Okay, I'll put my mind
in the realm
write
of
some down, and we can go through some because there's some you can imagine. Our conversations around sex and intimacy goes in every direction.
Yeah,
and then bowels and fecal incontinence and urgency, and then there's a bunch for bladder. So yes,
talking about it more has got to be helpful. Just having some openness around talking about it. would you say, is a good thing to be doing?
100%.
Like we're doing. Yeah.
Yes, it needs to be normalized because these are things we're very scared to admit. They're very personal, they're very
Yeah.
intimate, and they
Yeah.
can be related to long-term stories that we've been holding on to that we didn't recognize. And so I'm not a mental health therapist. I know when to refer for mental health therapy, but
Yeah.
there's definitely a lot of overlap with dealing with nervous system and trauma rehab that we do in this space. But
Yeah.
I
Yeah.
do refer
I
out.
think, and sometimes that could be enough, I suppose, to have somebody like you just say, oh, I know many people like this, or just something
That's right.
simple that doesn't require
Normalizing it.
years of
And doesn't it make sense?
You'd be like, oh, okay, yeah. Right. I remember asking you questions. You're like, oh, okay, maybe go read a book on this, which
Yeah,
I
that's
did, and
another,
sort
I
of
love
changed my
giving books.
life. Yeah,
That's
yeah.
usually I proceed that with, are you a reader? Because I have
Yeah,
a book.
yeah, yeah. Because there's some things
Yeah.
that you don't know. I mean,
Yes.
I always considered myself a well-read, fairly intelligent person, and just stuff
Yeah.
did not know. And then somebody's
Yeah.
got to tell you, and
Man, if I could go back in time and have my babies with what I know now.
right, right,
You know, you go through pregnancy and delivery with come in for pelvic rehab when you're
yeah,
pregnant. Learn how to best optimize your time in the delivery room based on your biomechanics and your fascial restrictions and where things are tight. There's certain positions that will do you better, and it's just setting you up for success. And prior to hitting menopause, if you're having concerns of what that will look like, come in and talk to somebody who understands those changes and can already set you up on a program to get you through with less symptoms.
Katie, you're my hero. And I'm sure
You're my
many
hero
other
too,
people's
Michelle.
heroes and will be their heroes in the future. So I thank so much.
That's a very overwhelming compliment, but thank you.
No, it's true. And so I will leave it at great and come in and see what can happen, kind of
Have an open
notion.
mind.
Yeah, yeah. Thank you. We learned a
Thank
lot
you, Michelle.
about
Good.
where you are and what you're doing, I think, and we can dig into all of this stuff in the future with a better foundation.
Thank you. Thank you for having me. This has been really fun, and I
It
love
sure
talking about
has.
all of the things that we do in pelvic rehab. I really appreciate
It's great.
you taking the time.
You bet. All right. I'll see you again.
She was working her way through a normal life with a body doing things without any strife. She asked a few questions, got a whisper, a shrug, got a dilator as big as a cider jug. Then one day she found a woman who said, let's talk about your muscles, your bowels, your head. She listened, she noticed, she didn't rush in, and suddenly things felt better again. Lighter, manageable, doable, stronger, wholer, calmer. Now they talk desire, poop and pee, and like when you can't stop. Things you don't hear at the coffee shop. It's not a miracle, it's not a cure. It's attention and patience and time. And sure, it's Katie. Pardon my pelvis.